these women, majority of them can be asymptomatic. When they do come with the symptoms, the most common symptom is heavy menstrual flow. When we say heavy menstrual flow, we have to keep one thing in mind, that is, the cycles are going to be regular. Pain is yet again another symptom. They can come with pain during the menses, which we call as dysmenorrhea, and even they can come with pain after the sexual intercourse. Good morning, I am Dr. Malavika JC, consultant obstetrician and gynecologist working at Cloudnine Hospitals, Bellanduru, Bangalore. So today I am going to talk in brief about a condition which commonly affects the women of the reproductive age that makes them to come and knock the door of a gynecologist, and that is uterine fibroid. Today let me briefly tell you what exactly these fibroids are, what causes them, and how we are going to deal with this condition. So coming to what is fibroids. Fibroids are basically a tumor, a benign tumor. That means it's a non-cancerous growth which arises from the uterine muscle. The smooth muscle of the uterus give rise to this growth. So based on where they are located, we can classify them into a submucous fibroid, that is when the fibroid projects into the uterine cavity, and when it grows within the uterine musculature, it is called as an intramural fibroid, and when it projects outside, we call it a subserosal fibroid. The fibroids are commonly known as leiomyoma in medical terminology, or also called as myoma. So what exactly causes these fibroids? What causes is actually not known, but it is an interplay of many factors. That is the hormonal factors, the genetic factors, growth factors, and even the ethnicity comes into play here. Coming to the hormonal factors, as I told, this is the problem of the reproductive age group women. So when it is in the reproductive age group, it means that the hormones like estrogen and progesterone are going to play a major role in the growth of these fibroids. So once the women is in the reproductive age group, with her increasing age, we find that the fibroids are commonly found in this group. And once they reach the menopause, the fibroids will shrink in size. And of course, family history does play a role. Those women with a history of with a mother having the fibroids, or with a sibling having the fibroids, yes, these conditions, the fibroids are known to run in the families. And also the growth factors like insulin-like growth factor also plays a role here. And ethnicity, when coming to the ethnicity, it's commonly found in the women of the African origin. In these women, we see that it is arising at an earlier age, and it is also growing at a faster pace. So how do these women present to us with? So these women, majority of them can be asymptomatic. When they do come with the symptoms, the most common symptom is heavy menstrual flow. When we say heavy menstrual flow, we have to keep one thing in mind, that is, the cycles are going to be regular. Most of the times the cycles are regular, and when they do come, they come with a heavier flow, both increased in duration as well as increase in the amount. That means earlier if they were bleeding 2 to 3 days in a period, now maybe the cycle has increased by 4 to 5 days, and even the number of pads that they're changing in the cycle is going to be more. And they also give a history of passage of clots, and sometimes there can also be flooding. And other common bleeding complaints with which they come is intermenstrual bleeding. Intermenstrual bleeding is commonly noticed in those women with a fibroid which is projecting into the uterine cavity. And based on the size, the position, and the location of the fibroid, they present with varied symptoms. One of the other common symptoms is a pressure symptom. When the fibroid is big enough, large enough, it can press upon the anterior structure, that is the bladder. So they can come us with increased frequency of micturition. That is, increased frequency, they feel like passing urine again and again. And also, when the fibroid is located at the cervix, at the level of the cervix, it can press upon the urethra. They can even come with a acute retention of urine. When the fibroid grows posteriorly, it can press upon the rectum. They can come with something like constipation. They can even come with the symptom of incomplete evacuation of the bowel. So various other symptoms, that is a big subserosal fibroid, if it twists on itself, then it can come with torsion. They present to us with acute pain abdomen, and when there is a degeneration of the fibroid, they can come with chronic pelvic pain. Pain is yet again another symptom. They can come with pain during the menses, which we call as dysmenorrhea, and even they can come with pain after the sexual intercourse. So these are the various symptoms with which a woman with fibroid present to us with. So who are at risk? As I already told you, that it is the levels of hormones which determines the risk. That is a woman who attains menarche at an earlier age. So what are the risk factors for this fibroid uterus? The exposure of hormones, that is estrogen and progesterone, for a prolonged period of time puts a woman at risk. Example, a woman who attained menarche at an earlier age, and an obese woman, that is a woman with a high BMI wherein there is peripheral conversion of androgen to estrogen, even they are at risk. And suppose a woman is never pregnant at all, in these women there is prolonged exposure to estrogen and progesterone. And also family history, all of them play an important role in determining the occurrence of fibroid in a particular woman. So having known what causes the fibroids, what are the risk factors, and how do they present to us with, what are the treatment modalities available to us at this point of time? So do women with fibroids always come to us with symptoms? No. 80% of the women are asymptomatic. That is, many a times it is an incidental finding. We find it on clinical examination. We even find it on ultrasound findings, and sometimes we can find it in the hysterectomy specimens as well. So 80% of them could be asymptomatic. And is there any risk of cancer in these women? As I said, fibroids are mostly and almost always benign. The chances of malignancy, the chances of sarcomatous change in this leiomyoma is less than 1%. So any postmenopausal women where there is an increase in the size of the fibroid, or whenever there is a rapid growth of a tumor in the pelvis, we have to watch for malignant changes, and the risk is less than 1%. And does these fibroids affect pregnancy? As such, the women with fibroid, they don't have any difficulty in becoming pregnant. Only in some percentage of them, they do find it difficult to become pregnant whenever the fibroid is such that, or it is in such a strategical location, or it is big enough to alter the tubo-ovarian relationship. So whenever the tubo-ovarian relationship is altered, it alters the ovum pickup mechanism. So that is when these women can present with subfertility. And when they do become pregnant, usually the fibroid will not affect the course of the pregnancy. So when the fibroid is such located, that is, if it is submucous fibroid, if the pregnancy implants on the submucous fibroid location, then the chances are that there can be implantation failure, and the chances are that they can also come with spontaneous miscarriage. If a fibroid is very big enough, so that can even alter the contractility of the fibroid, and hence it can cause preterm labor, preterm premature rupture of membranes. And if the fibroid is located in the cervix, or if it is big enough to obstruct the labor, it can even cause an obstructed labor, and it can even cause malpresentation. The chances of cesarean section is high in these cases, and also we do expect postpartum hemorrhage affecting these women with fibroid, since it affects the contractility of the uterus. So now let's take a look on the treatment modalities available for fibroid uterus. So what are the treatment modalities available for women presenting with fibroid uterus? Since most of the women are asymptomatic, or most of the women present with small fibroids, these women need not be treated. Only those symptomatic women need treatment. And the treatment depends on what is the size of the fibroid, the location, the position, and how big the fibroid is, and whether the woman wants to retain her fertility, whether the woman wants to retain her menstrual function, and woman wants to retain her uterus. So taking all these factors into consideration, we draft a plan to treat the women with fibroid uterus. So coming from the basic management, a woman who presents with pain, so we can treat all these women with simple analgesics, and when they come with a heavier flow, we can treat them with antifibrinolytics, tranexamic acid, all these basic drugs, and even we can give them hormonal treatment like combined OC pills, we can give progesterone antagonist, we can also offer them selective progesterone receptor modulators. Since these fibroids express estrogen and progesterone receptors, we can use all these hormonal treatments as well. And when we come with heavier flow, we can always use something like an intrauterine device which can be fitted in the uterus, which controls the heavy flow during the menses. But these intrauterine devices can only be placed on those who have a regular cavity, and the fibroid should not be very big in such cases. We can also offer them injections like GnRH agonists, which can be given once in a month for 3 months. These GnRH agonists are known to shut the hormones, reduce the vascularity, as well as reduce the size of the fibroid uterus. So coming to the surgical management. Surgical management, we have two options. Either we can remove the fibroids itself, or we can remove the fibroids along with the uterus and the cervix. When we remove only the fibroid, we call it as myomectomy. And this myomectomy is usually chosen, or it is offered to women who are desirous of retaining their fertility, who are desirous of retaining the uterus as well as the menstrual function. So we can do myomectomy by various approaches. We can do it either open myomectomy, or we can do it by a keyhole surgery, that is called lap myomectomy, or when the fibroid is accessible into the uterine cavity, we can always do it via the hysteroscopic approach. So 3 different modalities of approaches are available to remove the myoma. So when the woman has multiple fibroid uterus, or too many fibroids, or too big a fibroid, it is covering entire uterus, and when she doesn't want to retain her fertility functions, or when she doesn't want to retain her uterus and the menstrual function, then she can always opt for hysterectomy. Hysterectomy can be approached either vaginally, abdominally, or laparoscopically. That depends on the surgical expertise as well as the patient characteristics. There are certain other modalities which are available to treat these fibroids, like uterine artery embolization. In this, what we do is, as you know, the fibroid is supplied by a blood vessel. So blood vessel which comes from the uterine artery. In this case, we embolize the feeding vessel to the fibroid uterus, and hence we are going to embolize the branch of the uterine artery here. So what exactly happens here is, because the blood supply is lost, the size of the fibroid comes down and the vascularity comes down. But here the problem is, the chances are that there is a recurrence of fibroid after 1 or 2 years. It will just relieve the symptoms for time being. And one more modality is MR guided focused ultrasound. Here we are focusing the ultrasound waves on the center of the fibroid uterus. This also helps in reducing the size of the fibroid. Let's check into the other different modalities which we use to treat the fibroid uterus, and one of them is uterine artery embolization, wherein we embolize the feeder vessel which is supplying the fibroid uterus. So thereby the vascularity to the fibroid comes down, as well as the size of the fibroid reduces. So this is a temporary modality of treatment because the effect will last only for 1 or 2 years, and the symptoms are known to recur. It is mainly suggested for those women who want to avoid the major surgical procedure. And also MR guided focused ultrasound is one more modality wherein the ultrasound waves are focused right at the center of the fibroid uterus, thereby causing lysis of the cell as well as reducing the size of the fibroid. So these are the non-surgical modalities which offers temporary relief of symptoms as well as causes temporary reduction in the size of the fibroid uterus, especially those women who wants to postpone surgery, or those women who want to postpone the definitive modality of treatment for some time, they can go for these. So these are the various treatment modalities, and this is a brief overview of how a woman with fibroid presents to us and how we deal with them. So just remember, each person presents with different symptoms, and the symptoms and the treatment is tailor-made for each woman. To summarize, uterine fibroids are a common condition known to affect the women of the reproductive age group, and we already know that what are the risk factors and what are the treatment modalities available for this. So whenever you encounter any such condition, please do contact a qualified gynecologist, and please do explore the treatment options available for you. And for more such information related to the health, thanks for watching. If you do like this video, put a thumbs up and do subscribe for our YouTube channel, Cloudnine Hospitals. Thank you.